Hi, okay, so we are starting with our second extension in health psychology, which is adherence. So we did patient and practitioner. Now we're just going to focus on adherence. Adherence, but we're doing the first topic. We're just doing the introduction, and then we're going to move to the first topic, which is basically types of non-adherence and reasons why patients do not adhere. We're again on the same black book. We're following the same black book, page number 226, continuation, right? So what adherence? Generally, if I look at the term adherence, it means to abide by something or to follow something. So we adhere to the rules and regulations of society, we adhere to the laws of society. So we adhere to whatever our parents say. So it's general rules, regulations. So that's everything that we abide by, right? So anything that we abide by, anything that we follow, anything that we listen to and implement in our lives is basically called adhering that certain thing. So that in holistically, that is a whole concept known as adherence, right? So one of the issues to consider with adherence to medicine is request. Is the type of behavior we are asking someone to do. The types of requests fall into a number of categories. So basically, when you're talking about patients and practitioners, or when you're talking about medicines, or you're talking about general health, the one thing that you need is for patients to adhere. The one thing that you need is for patients to listen, and we basically need them to do that in different forms. So one of them is that we need them. So basically, a doctor or a practitioner can ask them to adhere in different forms. Okay, so the first one would be that you can just ask them for short-term compliance. Okay, so that just means that taking tablets, let's say twice in the week, or just twice a day, just for 2 days or 3 days. So that's just short term, or maybe just 1 week, So that's short term compliance, and that's what you ask your patient of. That's what you expect them to adhere to and listen to. So that is basically a request for short term compliance. Again, this is again short term, and compliance means to abide by. The second one that we can ask from a patient is request for positive additions to lifestyle. So, for example, we can ask a person to inherit exercise in their lifestyle, or have protein, or have healthy food. So, all of those things would be asking them to add something new to their lives, and that would be another form of asking for adherence, basically. Then the third one is that we can request or ask them to stop certain behaviors. So for example, we can ask them to stop eating junk foods, to ask them to stop drinking alcohol. So all of these would be requests to stop a certain type of behavior. So whilst we are asking them to, let's say, make short-term compliances, let's say make positive additions, we can also ask them to remove something from their life, and that would and expect adherence. And the last one is that you can request them for long-term programs. So that's basically diabetes, dialysis, arthritis. So you all of these things would require them to comply by your rules and regulations, or your method of improvement for a long time period. So a doctor will always tell a patient with someone who needs to have dialysis, that they need to keep coming, need to keep having the checkup, need to keeping up with the medicines. All of those things would be required for over a long time period. So these are the different types in which we can ask them for adherence. Then they're talking about how chronic diseases are, only managed if people adhere. So chronic diseases are long-term diseases. Okay, so the ones like we just said, diabetes, or arthritis, these diseases are long-term, right? And these will only improve if the patient adheres. Otherwise, a doctor cannot keep running after a patient, and if a patient does not adhere, they will never get better. So that's basically just explaining which in which parts the adherence is the most important aspect, and that is when it's a long-term sickness. So that's just the introduction. We will move on to the first topic, which is types of non-adherence and reasons why patients do not adhere. So adherence is listening and abiding by. Non-adherence is not listening, not abiding by, not following the rules and regulations. So many different psychological reasons have been given for why patients do not always adhere to medical advice. Explanations for why patients do and do not adhere to medical advice fall into two categories. Some studies look for the explanation within the patient, and some studies look for the explanation by looking at the doctor's behavior. So they're saying that there's a lot of psychological reasons due to which patients do not adhere, and they have categorized them into two major broad categories, which is basically from the patient side, the patient's not adhering for some personal reasons, or it is from the doctor's side, that it is some issue from the doctor's side due to which the patient is not adhering. So um, now they're talking about types of non-adherence and the problems that is caused by them. So what happens when people do not listen or do not follow through? So non-adherence with medication is a complex and multi-dimensional health problem. The causes may be related to the patient, treatment, and the type of healthcare provider. As a consequence, substantial number of patients do not benefit from correct diagnosis and treatment, resulting in increased morbidity and mortality, as well as increase in both direct and indirect costs. Patients might not adhere during any stage of their treatment. So before I go to the stages of treatment where they would not adhere, we just need to know what they're talking about here. And they're generally saying that because people do not adhere, so the general idea is people do not adhere for many reasons, and when they do not adhere, the morbidity and the mortality rate goes up. So morbidity is when there is a, like for example, COVID-19, a holistic virus that has taken over the whole world, right? So similar that, you know, in the within the society, within a certain country, within a certain city, something just some disease takes over just because people are not adhering to medical advice. And mortality is basically the rate of people dying increasing. So that the death rate in the population is basically your mortality rate. So they're just saying that types of non-adherence leads to these things holistically within a society, and why people want the different stages in which people want to adhere are before, during, and after or end of treatment. So before treatment, they wouldn't adhere maybe because of poor description or of the treatment program, leading to a lack of awareness. So there, what would be the reason that people might not adhere before treatment is that they do not really understand the treatment. They do not really understand the prescription. They do not really understand the problem, and they are not motivated to fix it either. So that is one reason. During treatment, why would they not adhere? So, for example, they might take more of a drug or less of a drug. So, for example, all of us take a lot of melatonin. So that's basically sleeping tablets or sleeping pills, right? So, but they're not even prescribed in that extent. So that's again non-adherence. Even though yes, you are doing a certain thing, but you are doing it way more than it's asked. That will be counted as non-adherence as well because it is not listening. So for example, if our mom says go and clean your cupboard, and if we start cleaning every cupboard in the whole house, that is non-adherence as well because we did not adhere to what she was saying. Whilst that might make her really happy, but it's still non-adherence. So right, we understood that. During treatment, we might take more or less of a drug, take the drug at a different time than instructed. So, for example, if it's at 4 p.m., that does not mean 6 p.m. That will also be counted under non-adherence. May not complete their prescription. So, for example, if you've been asked to complete, you take the same tablets or follow the antibiotic course for over 2 weeks, and you just stop it after 1.5 weeks or just 7 days, that is also non-adherence. Only attend some follow-up appointments. So, for example, this is something I'm guilty of. I never go back once I've gotten the first course and I feel okay. I don't go back to the doctor. I don't even go back to the dentist after my teeth feels okay. So this is, you know, also coming under non-adherence, and this is basically during treatment how we would not adhere to medical advice and not complete any instructions. So for example, let's say the doctor has asked me to do exercise every single day and I'm just like, nah, never mind. That too will be non-adherence. At end of treatment, they might just end to, you know, they might fail to attend any of their follow-up sessions, that once they feel well they have to follow up and go. So this is mostly after operations, surgeries, fractures. People, once it's fixed, people actually don't go back, and that leads to long-term problems. And they may revert straight back to behaviors that were changed through treatment. So, for example, if you talk about fractures, again, something I'm guilty of, but then, you know, it's like do not play sports until and unless, you know, we will take off your plaster, but do not play sports until 2 more weeks, but then you just go ahead and you keep doing it. So you just revert back to the behaviors. You do not listen to the practitioner. That too will be non-adherence, but at the end of the treatment. So adherence can be defined as the extent to which a patient's behavior and following of treatment program coincides with the advice and guidance provided by doctors and other healthcare professionals. The reason for non-adherence could be intentional, that I am not taking any of these drugs, or non-intentional, that I forgot to take my medication. So again, these reasons can be intentional and non-intentional. Intentional would be, nah, I don't want to do it, I'm tired of it. Non-intentional would be, I forgot, I wasn't home, it's finished, anything like that. The reason for the non-adherence could be due to issues with the patient and the treatment program or the doctor's instructions. So like we discussed, that why do people non-adhere, that is divided into two broad categories. It could be either the patient's issue or the doctor's issue, or now they're saying that it could also be the treatment program, but majorly just the patient and the doctor. In the context of disease medication, non-adherence can be termed an epidemic. It is suggested that some older adult hospital admissions may be due to non-adherence with medication regimens, and these could have been avoided if medical instructions were followed. So they're saying that there are many cases in which you actually have to be admitted to the hospital just because you did not adhere. So in order to prevent all of that as well, you need to make sure that you adhere to the first medical advice that you're attaining. So how is a non-adherence from the patient side would be that patient decides that they do not need treatment. So if a patient says that I do not need treatment, that is non-adherence from their side, which would worsen a case. If patient does not understand the treatment, they're going to be like, no, this just seems foolish to me. I don't understand and I won't do it. The third non-adherence aspect that can come from the patient is that patient decides the cost of the treatment are more than their expected benefit. So they're just saying that this is way, way, way costly than it is benefiting me. So this is also, some people do this a lot, that they do not get blood tests and all of those tests because they're like, I would rather fix myself and with medications and stuff rather than getting all of these tests because these are so expensive and they won't even help me that much. And social support and demographic factors, that's another thing. So for example, so when you talk about social support, so basically when you're generally getting a lot of support from, let's say, your friends, family, and demographic factors, if you feel like it's just your age and you might just, it happens at this age, you'll just ignore the whole thing and not adhere to medical advice or just even visit a doctor. Then we have the treatment program, which could be the issue which can lead to non-adherence. A treatment program can be expensive, it can be time consuming, or it can be difficult to administer, which is basically difficult to understand, which are three major reasons as to why people would not adhere. Access to treatment program is not easy. So for example, when you talk about treatment programs for tumor, cancer, these treatment programs are not accessible. They're not easily accessible, which is why it is just so difficult to get all of that thing done. Even to get chemotherapy, it's a whole task. Then we have what could be the issues from the healthcare provider. So that's basically our doctor or a practitioner. So doctors does not stress the importance of the treatment. So doctors probably just a little lenient with the patient, thinking that they will listen regardless, but they do not stress upon the importance, and that leads to non-adherence, which obviously leads to repercussions. Or doctor does not give adequate details how to administer a drug. So for example, this happens a lot in the cases of kids. Okay, so it's like you do not explain well as to how a certain thing needs to be managed. Even when you're using insulins for diabetes, most people do not really understand how they need to be managed, and they just give themselves more insulin than they're supposed to. So all of these things will fall on the doctor that he hasn't explained it well enough. Moving ahead, failure to adhere to medical requests could lead to increased need for medical intervention, more frequent visits to the doctor, etc., etc. At best, non-adherence will cause a delay in improvement from the illness, and at worst, could increase the chances of illness developing into a more dangerous illness. So they're just saying that all of these things leads to non-adherence, and that what will that cause? That so this delay in treatment or this delay in adherence will lead to the sickness getting worse, and the worst thing that could happen is that it turns into a dangerous illness. So this is basically what's going to happen once you do not adhere. um, of all age groups, older persons with chronic diseases and conditions benefit the most from taking medication, and the more risk the most from failing to take them properly. So basically, chronic diseases, as I said, long-term diseases, and people also that are old. So both these conditions, when people are old and they have chronic diseases, they benefit most from taking medication. So they know that the medications are helping them, but they are also the population that will fail to adhere, that will fail to take them properly. Among older adults, the consequences of medication non-adherence may be more serious, less easily detected, and less easily resolved than in younger age groups. So they're just saying that when you talk about older patients, so their non-adherence is generally more serious, and it can lead to more serious consequences when you compare them to a younger group, because obviously a younger group can fight their illnesses way better than an old person. So that's a general rule of thumb, that older people, when they're sick, they're supposed to do better than younger kids holistically. Okay, so we're going to take a 1 minute break and then we're going to continue. Okay, so why patients, now we're looking at reasons as to why. We've already looked at the introduction as to why people might not adhere. Now we're looking at studies that have been conducted that have found evidence due to these reasons where patients do not adhere due to certain reasons that have been explained by different psychologists. So the first one that we have is why patients do not adhere because of rational or non-rational adherence. So basically, rational non-adherence is okay. So now we understand what the term non-adherence means. It means not to follow, not to abide by, not to listen, okay, not to oblige. Okay, now how can that be rational? How can not listening be rational? So for example, they are trying to say that people might not listen when they feel like it's logical not to listen. So for example, if a person thinks, if they have a certain condition and above that they have been given other medications that are making them weaker and weaker, they will basically list down the pros and cons of a certain medication or of a certain medical program, and they will see if the cons outweigh the pros, if the disadvantages outweigh the advantages, or if the disadvantages outweigh the benefits of that particular treatment program, they will not do it. So they basically do a cost benefit analysis where they look at the cost of a program, then they look at the benefits of a program, and if the costs are more than the benefit, they will not do that treatment program. And that is called rational non-adherence, that they have a logical reason as to why they are not following through or why they are not adhering. So Bulpit actually looked into that, and they're explaining it now. So rational choice theory is a framework for understanding and modeling why an individual will behave in a particular way. So why the individual is non-adhering, that is basically what he wanted to find out. In everyday life, we make rational decisions based on the information that is available to us at that time. When such decisions are made, we weigh the cost and benefits. What is the cost now and in the future, and what will be the benefits be? So this is basically what I was talking about, that if there's a cost benefit analysis, you look at the cost right now and future, you look at the benefits right now and future. If the costs are higher than the benefit, an individual would not change their behavior to adhere to a medical advice request. This suggests that one reason for non-adherence is actually a result of a well-considered and reasoned thought process that leads to the patient to believe that non-adherence is a better choice of behavior than adherence. So this is basically the one reason why non-adherence would make sense, under which non-adherence would be accepted. And that is basically when they know, when a patient lists down all those reasons and evaluates that particular choice and finds out that it is better to non-adhere than to adhere, and that is basically why they make this decision. So Bulpit considers that one of the reasons for non-adherence is a rational cost-benefit analysis, like I talked about, of the situation that patients make, and puts forward the risks and benefit of drug treatment for hypertension, abnormally high blood pressure in the elderly. So he is taking the example of hypertension, which is basically high BP for elderly people or elder people, okay, consistent high BP, okay, and that he's looking at. That's the one disease that he's looking at, and he's saying that they basically put forward all the risks that there are to this particular illness with the drug treatment that it has. So in Bulpit's 1994 paper, he reviews several pieces of research that suggest that individuals conduct cost benefit analysis when deciding on the course of action that they are going to take within the research. But Bulpit considers cost and benefits of drug treatments for elderly individuals with hypertension separately, and looks at research that has been conducted within these areas. So he basically had a research paper that he established or published, and in that he basically looked at several cases that were of rational non-adherence, and he mentioned those cases and what was the illness in those cases and why they did not really adhere to medical advice, and what research was done in these areas, and it was all related to hypertension. So when considering risks, Bulpit found that both EWPHE trial and SHEP studies found that there were many health risks to drug treatment in the elderly, such as gout, whatever you want to call it, chest pains, and change in bowel habits. When considering the benefits in the MRC trial for elderly patients, he found that coronary events were reduced by 44% with a mixture of drugs that were prescribed. So basically, the first thing where it's talking about EWPHE trial and SHEP studies. So that's basically types of scientific studies. So nothing too complex. Don't worry about that. So he basically looked, as I was saying, that when he had a research paper, he looked at different cases, he looked at different studies and researches, and he looked at this particular hypertension case, and he looked at different researches in that regard, and he found these where it was proven that when people used to implement these drug treatments for hypertension, elderly people, when they used to adhere to these drug treatments for hypertension, two things would happen. The first thing is that when they're talking about bowel diseases, or they're talking about gout, chest pain, so this is to do with the stomach, so that would remove, that would affect their stomach in a very very bad way. So they would stop, they would be constipated, they would have loose motions, they would, all of these things would happen to them. So any, their whole system with the with from starting from their throat to their stomach would be ruined due to this treatment that they would take for hypertension. So gout is basically when you're just to give you an idea, it's basically when you're all the minerals and all of the fluids from your stomach are just flushed down to your intestines, and they just stay there. They're not, so they don't break down food anymore. And when you talk about chest pains, that's basic normal chest pains. And when you talk about bowel change in bowel habits, so but that's basically change in your food habits, eating habits, general everything to do with your stomach. All of those things change when you're stressed. You start, your stomach starts hurting. So holistically, your bowel is basically your stomach, and that is affected. So that's one thing that they found out, when that he found out and established it with this research paper. And the second thing that he found out was that when you do not take this particular drug treatment, there is less chance for you to have a coronary heart disease, right? So it would reduce the chances for you to have your heart disease by 44%. So there is a huge chance that if you take this drug treatment for hypertension, you would have a heart disease, compared to not taking it, where you would, the chances would be reduced by 44%. So that's one thing that he has been established. He concluded that the benefits from treating combined systolic and diastolic hypertension in elderly patients far outweigh the disadvantages. When considering the benefits of anti-hypertensive treatment, it is important to consider benefits other than stroke reduction. He also makes the reference to difficulty in measuring cost benefit interactions in individuals. So he has basically concluded that it is better to not take the drug treatment prescribed for hypertension in order to have a relatively healthier lifestyle, because that particular treatment, whilst it would improve your hypertension problem, it would affect other areas of your body, and it would affect you holistically and cause other things to happen, and that in itself is not very healthy. So, and then lastly, he also talks a little bit about, they haven't told us that, but he generally talks about how it is also difficult to have this cost benefit analysis, because you need a lot of information to do this. But generally people do it after interactions and stuff. So that is why patients do not adhere, rational non-adherence. We are going to move on to the health belief model after a minute's break again. Okay, so we've got the health belief model by Becker. Health belief model holistically is basically looking for that when a person is going to start taking preventive health measures, basically. So when is a person going to start adhering? That's basically what it focuses on holistically. But then when we look at more details of it, there's two things that we will be looking at, which is basically the first one is evaluating a threat, and the second one is a cost benefit analysis, right? So that basically means that when a person is sick or when they are asked to follow a particular drug treatment program or any particular medical advice or asked for adherence, they will look at two things. They will evaluate the threat, so they will evaluate their problem, how serious is it, and the second thing they're going to do is the cost benefit analysis. So again, we're going to read. The health belief model aims to predict when a person will engage in preventive behaviors such as stopping smoking, taking up exercise, attending checkups and yearly screening tests. So when will they do this? So what phase in their life or what phase will they hit psychologically that will motivate them to do this? That's one thing. So that's basically what the health belief model looks at holistically. According to health belief model, the likelihood that individuals will follow medical advice depends on two assessments that they make. So they're saying that they would start doing all of this based on two different assessments that they make, which will be A, evaluating the threat, and B, cost benefit analysis. So initially they're looking at when will a person start adhering, and secondly they're looking at when basically what's the likelihood that they're going to start, like, sorry, wait, let me just rephrase that. So we're just looking at when will they start it, and secondly what will motivate them to start it, right? So they will do the two assessments. They're going to evaluate the threat, they're going to evaluate the cost benefit analysis, and that will motivate them to start using preventive measures. So the first part where they're evaluating the threat, so when evaluating the threat, there are several factors that can influence a person's perceived threat of illness, including perceived seriousness, perceived susceptibility, and cues to action. Other factors also likely to affect this assessment are demographic variables such as income and level of education, age, and sex of the individual. Now, before I explain what this paragraph means, we're going to look at the table that has been given below, where it's saying individual perceptions modifying factors, likelihood of action. So this, you need to remember that whatever these paragraphs are saying is directly related to what is given in this table. The table is explaining us whatever the paragraphs are saying. So now the first paragraph, like which I just read, they're saying that when a person is evaluating the threat. Now, what does evaluating the threat means? Looking at the strengths and weaknesses of a particular sickness. The threat is the sickness or whatever the issue is. So looking at the strengths and weaknesses of that particular issues, understanding. So evaluators understanding that issue. So when they're doing that, there are a lot of factors that motivate that or that affect that. So the first one they're talking about, first a few ones are basically individual perception. So what individual thinks of that issue, how serious do they think it is, how susceptible do they think they are to it. So how serious would be, how serious is it, right? So how much should I take care of it? How susceptible means that how weak am I, how much will it affect me. Then they come to the cues of action, which is basically, okay, now I need to take action towards this particular issue. They're also motivated by, or they're also affected by demographic factors. So whenever they're evaluating the issue, they also take into account the demographic factors, which basically means they take into account their age, they take into account their income, they take into account their level of education. So they look at all of these things. So do we have enough income to look at this for a long term? Do I have enough money to inherit this long term program? Or is it because of my age, and am I too young to have this, am I too old to have this, what is it, right? So they look at all of those things when they're evaluating a particular issue. Then they're saying, so they have given us an example. So for example, if a person is obese, they might be in danger of developing a heart condition. They might understand that this is a serious condition, but they might believe that because they are still quite young, they are unlikely to develop this problem just yet. So they have given us an example of how demographic factors would affect them while they're evaluating the threat. So if they feel like they're too young to have a disease, they'll be like, okay, no, you know what, this cannot happen to me, I'm too young for this. Therefore, they might judge the threat as minor. So this will lead to them evaluating the threat as minor, as something that's just small. Even if we judge the threat to be serious, we are only likely to act if we have a reason to act. This cue might be an advertising campaign, or it might be the diagnosis of a friend with heart disease. Now they're saying that even if we think, when we have evaluated the threat, even if we think that it's not a minor threat, it's actually something serious, we will still not be motivated to act upon it. And we will only be motivated to act upon it once we have the cues of action. And what will be these cues of actions be? It might be some advertising campaign which tells you how bad this has become, or how common it has become, or it might be a friend or a family getting diagnosed with the same thing, and then you realize, okay, you know what, I should get it checked. Then we move ahead to the cost benefit. So this is basically just looking at the first part of it, which is per person evaluating the threat and then leading towards adherence. Then we have the cost benefit assessment, which is the second one, which looks at whether the perceived benefits exceed the perceived impediments. So again, benefits and cost, we analyze them, what's more, what's less. The barriers might be financial, situational, or social. The benefits might be improved health, relief from anxiety, and reducing health risk. So they are just saying that the cost or the barriers would be that it could be very expensive, that would be financial; situational, that it is very difficult to find that treatment program; and social, that you don't want to be categorized as that in society, or you're just fearful to face that within society. And they're saying that other benefits, when you these are the costs, but when you talk about benefits, that would be that you would be healthy, you wouldn't have anxiety, you would have reduced health risk, you would maybe have a longer life. So all of those things. um, so that looking at just overviewing the table on the table in below just for a second. So we have individual perception, so that's again susceptibility, seriousness, etc. We have modifying factors, which is changing factors, that's demographic variables, that's socio psychological variables, that's again personality, social class, all of those things. We have structural variables. So these all of these affect the perceived threat. Okay, so how dangerous do we think the disease is? And that actually leads to cues of action, which we've discussed. It could be the illness of a family member or of a friend, of awareness campaign. And then this will eventually lead to the cost benefit analysis, which is looking at the benefits and the barriers, and how likely are we to take actions. Not the second or 8.7. Don't look at 8.7 yet, because that is not about the health belief model, that's the compliance model. So Becker basically looked at two different models. Health belief finishes here. Compliance model is another thing that she looked at, where she built upon the health belief model to explain why a patient might comply or adhere with medical requests. So she wanted to explain why a patient will adhere. So that's why she built upon the health belief model. The model could be used to predict factors that would influence the likelihood of a patient adhering to any medical request. The perceptions of the child's, patient's mother are examined. Within this model, as it was believed that it was usually the mother who decided whether a child was sick or what care could be assessed at that point. So she is using the example of a child who was a patient with his mother, because she said she believed that it was the mother who would make these decisions as to whether a child should get treatment or not. So she is now trying to figure out that why would people comply or adhere with medical advices beyond those two assessments. So those two assessments do make sense, but why else would they do it? So the one example that she's using here is because their mother has asked them to. So the compliance model introduces the concept of health motivation. It considers both negative aspects of health that could motivate action, or as well as physical positive factors such as general awareness of health concerns. So she's saying that the first thing she's saying is that there is a concept of health motivation, which could be negative or positive. So something negative you see about your particular illness will motivate you to go and get it checked or adhere to medical advice. Or something positive, you just want to make sure that you're healthy, you want to make sure that you can be healthy on a trip or something like that. That too will motivate you to go and adhere to medical advice. So it's both positive and negative factors that generally will move you towards health motivation. The second concept introduced in this model is that of incentive value of adherence. These are factors about the illness that contribute to the decision to adhere, such as child's vulnerability and the degree of harm. So they're saying that it is also about the incentive value of adherence, that how important is it? So what will happen if we do not adhere? Will our kid die? Will we die? So if obviously that's the scenario, you will adhere no matter what. So again, it is again, what is the value of adherence? How important is it to adhere? And the third one is the mother's perception that the doctor's instructions will result in a reduction of the threat. So if the mother thinks that the doctor is right and it will reduce the threat, we are most likely to do it, or the mother is most likely to motivate her kid to do it. As this is a model of compliance, the patient has already seen the doctor and is presenting symptoms, therefore the cues to action are already present. So for example, they're saying that this is not about a health belief model, this is about compliance. This model revolves around compliance, which is basically listening and adhering. Okay, so listening is complying by, okay, abiding by. This is about abiding by. And because of that, when you look at when you look at obeying a certain thing, you just need to make, that at that point we already know that the person is sick, we already know what their treatment is, and the cues to action are already present. Okay, so that basically means that they are already motivated to fix it, or they are already moving towards the cues of action. So now they, so this is one thing that needs to be established. However, the readiness to take the recommended action is still susceptible, so they're just still not ready to take it. So they know they need to, but they're still not ready to, and that is basically what might cause non-adherence. So Becker suggested these 5 variables, which was motivation, value of threat reduction, reducing threat, cues to action, and modifying factors, which combine to predict the likeliness of a mother taking the recommended health action prescribed by a doctor. So she is saying, Becker suggested that this, when you look at a case of a mother and a child, she is going to look at 5 different variables. She is going to look at the motivations to adhere. She is going to look at how valuable it is for me to adhere, how will it reduce the threats. The third thing is reducing threat. So again, how much of a threat will be reduced by this action, the cues to action, what all she needs to do, and the fifth one, which is the modifying factors. Again, that different things, financial, situational, sociological, she will look at all these 5 variables, and then she will choose to adhere and or comply by. So compliance. The model was supported by a study conducted in 1971, where a random sample of 125 cases was drawn from a population of children being treated in the comprehensive child care clinic at the large teaching hospital. The children were aged from 6 weeks to 10 years old, and all were placed on a course of liquid oral antibiotic and a follow-up visit. An hour-long interview was conducted with each patient immediately after the doctor's appointment. Adherence was operationalized by asking the name of the medication, the number of times it should be given, the date of follow-up appointment, together with subsequent behavior such as administering the medication and keeping the follow-up appointment. So basically, they're saying that they conducted this research with 125 cases from the CCCC, and that basically showed, so they basically asked people to, the mothers and the parents and the child, to take this liquid antibiotic course, and they were also supposed to do a follow-up appointment. And with this, a 1-hour interview was taken from taken with the doctor and the patient, and the operationalization of adherence. So that's basically how was adherence measured. Was basically they were asked the name of the medication that they were taking, how many times they were taking it, did they or did they not attend the follow-up appointment, and just looking at administering the whole process of medication, how if they're taking it on the right time, they're just following through on that. So results showed that mothers who adhered to various aspects of the prescribed treatments were more interested in their child's health in general, that they perceived that illness was a substantial threat to their child. So basically, they're saying the ones that adhered were basically generally more scared. They cared more about their child's health, and the level of threat that they felt was actually high, and they actually believed that this would reduce the level of threat, which is why they actually engaged in this behavior, and they actually followed through with their child on this particular medical treatment. The model appears to be useful in the explanation and prediction of compliance behavior. Variables are found in each major category of the model which are related to compliance, both at general level and dealing with specific illness studies. So they're saying that this whole model is looking at each and every variable, and it is generally helpful to understand why people comply by and why people do not comply, especially in the case of children. And when you go back and you look at the table, now it'll make sense to you. So the first heading says mother's psychological level of readiness to take action, which would be again which would be basically how ready is the mother to take action. That would be motivated by motivations, which is again physical threat, the attitude. Then the value of threat would be another thing. The probability of the threat reducing would be another thing, which would motivate her to take action. The modifying factors are again the cues to action, what will prevent, what will motivate, readiness to take action. And the cues to action, they're talking about different things. So demographic, family problem structure, family experience. They're talking about advice from others, follow-up appointments, all of these things. And compliance is basically how many, why, if she would comply, why would she comply, so, and what is basically compliance, how is compliance measured, so that would be attending the follow-up appointment, keeping appointments, going to the doctor, all of this would be complying by the particular advice. So we've looked at two things holistically here. We've looked at the health belief model, which is looking at two assessments, the evaluation of the threat and the cost and benefit analysis, and then we've looked at the compliance model where the cues of action already exist, and we're looking at why a certain mother and a kid would comply, because the mother would have different factors that would motivate her to force or convince her kid to comply or make her kid comply, because obviously they're children. So yeah, that's pretty much it. We're going to look at the evaluation and issues and debates at the end of each of the lectures from this topic. Thank you.